Thank you very much for the introduction. I work at the Medical Imaging Center of Semmelweis University as an MSK radiologist, musculoskeletal radiologist, and also I'm a PhD student at the Translational medicine program. My vision is to provide state-of-the-art diagnostic care for patients with bone and soft tissue tumors, and my mission is to determine the optimal imaging algorithm of chondrogenic bone tumors that can eventuate higher clinical decision-making efficacy. So what are my specific goals? I will present you thoroughly both of my topics. So let's move on to the first one, which is the investigating the diagnostic accuracy of advanced MRI techniques in patients with cartilage-forming bone tumors. So what is the background of it? The majority of chondroid tumors are actually benign, but their malignant counterpart, chondrosarcoma, is quite rare, but it also accounts for 25% of all primary malignant bone tumors, and the accurate grading and differentiation between these two entities are needed because the appropriate therapy differs greatly among different tumor grades also. For example, for enchondromas, a wait-and-see approach is the one that is right now implemented in practice. And for low-grade and high-grade chondrosarcoma, the therapy even differs from each other. So what is the problem? The problem is that reliable differentiation and grading of these cartilaginous neoplasm is a challenging task for radiologists and pathologists because it is sometimes very hard to differentiate, even with pathological tissue sampling, the differentiation between enchondromas and low-grade chondrosarcomas, and conventional MRI protocols, unfortunately, are not accurate enough in differentiating these two entities, and even false positive cases are quite common in our clinical practice. Lately, relatively new techniques were started to be used. For example, dynamic contrast-enhanced imaging in the MRI field, and diffusion-weighted imaging also in MRI, and I think the most promising new technique, radiomics, were started to be used. So we would like to see how these new techniques perform comparing with the conventional MRI evaluation. So the clinical question is, what is the diagnostic accuracy? Is there any advantages? Is there any advantage of using these techniques comparing with the conventional one? So because this is a diagnostic accuracy test, we use a paired model. So our patient population is patients with verified chondroid tumors, either with histology or with radiographical follow-ups. The index tests are DC MRI, dynamic contrast-enhanced MRI, diffusion-weighted imaging, and radiomics. And the reference test is, of course, the conventional MRI. So what is the diagnosis? What is the D in the paired model? Is the cartilage-forming bone tumors grades and even the dignity of the tumors. Our hypothesis is that emerging or novel MRI techniques perform better compared to conventional MRI. And the clinical implication is, of course, that better preoperative clinical radiological decision-making in the treatment of chondroid bone tumors. So we did a systematic search in 4 large databases, and the search key is shown on the slides. And all in all, we found 276 eligible articles, but only 12 were selected later on with my co-investigator. So we have 12 articles, and 9 of those were about radiomics, and only 2 and 1 were DC MRI or DWI MRI articles. So we excluded it from meta-analysis, from the meta-analysis project because we didn't have enough data. But we found 9 radiomics articles, and we used them for meta-analysis. So what outcomes we decided to choose? We compared the radiomics and the conventional MRI techniques for differentiating benign versus malignant chondroid tumors, benign versus low-grade malignant tumors, and low-grade versus high-grade malignant tumors. The outcome measures were accuracy, sensitivity, specificity, and area under the curve. Okay, so as you can see, these are the finished, I don't know, the title has vanished, I don't know where it is right now, but these are the finished analysis, all. So for radiomics, we could compare the benign versus malignant because we had enough data for that. But unfortunately, we didn't have enough data for the benign versus low-grade malignant or the low-grade malignant versus high-grade malignant comparison. So we could only compare the benign versus malignant differentiation in the radiomics. And unfortunately, as I mentioned before, we didn't have enough data for the DC MRI and the DWI MRI, so we excluded it from our research. So this is the forest plot that we get. You can see that we had 4 subgroups, 3 of which were radiomics, T1 weighted imaging, T2 weighted imaging, or other weighted imaging, and the sensitivity and specificity of the radiomical analysis. And we had the expert group, which is the conventional MRI group. And you can see that in the conventional MRI group, the sensitivity was very, very low compared to the radiomics counterparts, for example, T1 or T2. And also the specificity was not high enough in the tumor grading or tumor differentiation part. And the area under the curve for the radiomics analysis were promising. These values were fair to excellent, but unfortunately we had quite a wide confidence interval, which can be translated into that we couldn't use it reliably in a test data set later on, because we have such a wide confidence interval here. So the strengths of our analysis are the rigorous method selection criteria and inclusion-exclusion criteria, and we also added radiomics quality score to our analysis. The limitations are we had such a small sample size, such low quality of results reporting in our meta-analysis, and unfortunately partially overlapping patient population. So conclusion is that we have insufficient number of articles with uncertain results, poor quality of radiomics analysis, and flawed overall methodology. The implication for practice is these are promising new techniques, these are theoretically feasible techniques, and they could provide us with higher pre-surgical diagnostic accuracy. The implication for research is that we have such a low number of related articles, non-standardized steps of radiomics analysis, and low number of comparative studies with conventional MRI. So we just finished our first project, as you can see here, and we would like to send it for internal review as of tomorrow. And my second project has just started. I would just want to introduce it. We would like to do our own research on this topic. So we would like to do a retrospective diagnostic test study building radiomics analysis, a radiomics test. And as I mentioned before, these are the problems, only a few articles that we have, and we have the National Bone Tumor Registry that contains all the relevant data, and we would like to use that to see how our system has as far as the diagnostic accuracy is concerned. So the PERD model is the same, and I would like to thank you for your attention.
Congratulations, excellent presentation. My question is very short. We all know that the MRI investigation lasts relatively long. The new method that you should like to propagate, and there are positive signs by using this method, will it accelerate or prolong a little bit the investigation with the conventional ones? Because many of these patients who had pain, who are old, are unquiet and difficult to keep them quietly in the gantry.
Thank you for the question. We have three emerging techniques. The first one, radiomics, it does not have any effect on the examination time because it's a so-called post-processing process. So our acquired data is being investigated by machine learning later, so it does not prolong the examination time. The DWI technique is already in routine usage, so DWI in many cases are mandatory to be used. So it is in our protocol in the university, so it is not something new, and it does not add more time to the examination. But DCE is the one that is a bit technically demanding because it investigates the perfusion of the tumor, and it should be measured dynamically. For example, every 7 or 8 seconds, a measurement should be made for as long as 3 to 5 minutes. So these 3 to 5 minutes had to be added or has to be added to the original examination.
Thank you very much. Another question. Nowadays, if an investigation, a diagnostic MRI investigation is carried out somewhere, the radiologist in a different country or a different city is sitting and receives on the screen the pictures. The result of such a good method, a new method, can be diagnosed by the so-called average radiologist, or can be evaluated only a very specific center with specific, very well-educated, specific radiologist.
In this case, I think a tertiary center should be used for this investigation, because it is such a small field of radiology that it needs subspecialized radiologists to report these kind of examinations. But generally, if we would just theoretically would answer the question that radiomics or DC or DWI should be reported by a teleradiology in a teleradiology services, my answer is yes, it can be, if the radiologists are specialized for that region that he or she would like to report remotely. So I don't see it's a problem generally, but in this case it would be a problem if not a subspecialized radiologist would do the interpretation of these new techniques.
I also want to congratulate you. That was really very nice and clear to me, which is important because I'm a non-professional in this field. Except one thing. What do you mean by radiomics? You didn't explain that. I think it's very, very important, because I think at the moment we are comparing apple to peach. And I think that this can be one of the reasons why we're unable to find the proper articles to compare your studies to.
So radiomics actually, in 2 words, texture analysis by an algorithm which is built by radiologists and engineers.
But there are several algorithms.
Several algorithms.
So that's the problem, I guess.
Yeah, that's why we have such a wide confidence interval, because if you overfit a model, it can have devastating effect.
For me, it's enough. Accuracy. Thank you very much. It's timing. I would love to discuss that. And I'm sorry about the audience, but we don't have more time to ask questions. Congratulations. That was very good.